I appreciate the opportunity to participate in the program and share some of what we're doing in the Office of Specialty Care and Specialty Care Transformation with you all today. I hope in the next 20 minutes that I'll be able to share with you this innovative program and also do a demonstration of this program as well. As Dr. Agarwal pointed out, this is a program, an initiative that really is targeted at enhancing specialty care delivery in some of our more rural and remote areas of our country and the veterans that we serve in those more than 850 community-based outpatient clinics that have difficulty at times accessing specialty care. This is an enhanced or a different way of using the telehealth technology to train and educate primary care providers who then over time within one specialty care area, cardiology, hepatitis C, HIV, become mini experts or are able to deliver some basic specialty care that is available through those primary care clinicians. So I'm going to share with you a few words about or some specifics about the program, and then what I'd like to do is really demonstrate this program and what it's like. You all will be the audience, and the primary care serve as one primary care provider participating, and we will get up on the screen here our heart failure team in Cleveland, as well as a primary care provider in Warren, Ohio, who regularly participates in the heart failure scan echo program. This is based on a private sector program. Dr. Aurora at Project ECHO demonstrated the effectiveness of hepatitis C echo, and this is an adaptation of this for not only hepatitis C, but I'll share with you some other specialty care areas which we are adopting and adapting our version called Scan Echo for. We see this as a knowledge transfer program where there is not physically a patient present, although telehealth technology is used. And as you'll see demonstrated on the screen, multiple providers dial in and have an opportunity to discuss cases. So it is about patients and real patients, although patients are not physically present at that time. This slide is a smaller version of what we have up on our map at our table over there, which highlights some specific areas where we are implementing Scan Echo and what conditions we're doing that for. Hepatitis C, pain management, diabetes, heart failure, chronic kidney disease, COPD, and even some preoperative and vascular surgery, some conditions that are extremely common in primary care practice. This is a map of the 11 centers that have been funded in the locations across the country that serve as the specialty care hubs. They are extended then to service not only in their own network, but with the partnership of the Office of Rural Health. Rural Health has enabled primary care providers that are not in networks that have a center to also participate through that telehealth equipment. So I'll give you a few words about the process, and then we're going to go to our live demonstration. The primary care provider submits a case to the specialty care team. And the team is not only a specialist, a cardiologist, but the team also includes a clinical pharmacy specialist that has expertise in heart failure, a health psychologist, as we'll see up on the screen in a moment, who also has expertise in heart failure, as well as nurses and nurse practitioners who participate as a team-based approach to heart failure care. Multiple primary care providers will dial in and participate with that, and there will be a case or many cases that are discussed based on real patients that those providers are encountering in their community-based outpatient clinics. In addition, there will be a didactic session for which any providers that participate get continuing medical education within, and those didactic sessions are enduring materials that have been developed to be used across nursing, pharmacy, for physicians, physician assistants to get credit, and they are based on the VA and Department of Defense clinical practice guidelines. Benefits of the program thus far, we've seen some benefits in terms of the number of miles that patients save because they are able to see a primary care provider and get some of that heart failure care in conjunction with the specialist in their local community-based outpatient clinics. And we're looking at improvements in terms of patient indicators over the next period of time and really looking at the impact of this program at the patient level and that they're getting care from a provider who knows them relatively well, who is connecting with the specialist, and that relationship enhances the care that gets delivered. From the provider level, where we've gotten in some preliminary data about how really successful this is from and satisfied providers are from both a specialist side as well as a primary care side. And I think that we're going to continue to look for lessons learned and how to support and enhance this program. What I'd like to do now then is turn to our live demonstration. If you could pull up the bridge, please. And I think I'm going to ask one of our audience members to come up and read the case. He is from Mr. Denny Bowler, and he is representing AMVET. Is that correct, Mr. Bowler? And he has been very gracious to serve as our primary care provider and read a couple of sentences to our heart failure team and Dr. Bassiano, who is on the line as well. If we could pull up the heart failure team as well, that would be great. Sure, go ahead.
Okay. I have a 55-year-old male veteran, has a history of heart failure for 2 years. He's been complaining of abdominal fullness, and his water pills aren't working. His ejection fraction is 35%.
Thank you very much, primary care provider Dr. Bowler. So we'll now turn to... He was asking a lot of questions at the Scan Echo table, so I wondered if, and I appreciate your participation. So heart failure team, they are in Cleveland. Dr. Jose Ortiz, who's our cardiologist in the center. On the left is Dr. Kim Schaub, who's a health psychologist, and Dr. Sherry LaForest, who's our clinical pharmacy specialist. This is the Scan Echo room in Cleveland, Ohio, which they will sit in. And if you'd like to respond to that patient presentation, I'd love to hear that. And I think the audience would as well.
Sure. First and foremost, great presenter. If he ever needs a job as a presenter, he should apply in Cleveland. The presentation is pretty much of a relatively young patient, and younger patients tend to have more abdominal symptoms than elderly patients with heart failure. It clearly sounds like Mr. Smith is really volume overloaded, and he may have what is called diuretic resistance. I think that's a great point to talk about in a second. Of note, if his weight are not changing and he is eating less, that's one of the times we may be confused thinking that the person is okay, but he may be losing real weight and gaining wear gain, which is more concerning. So Sherry, can you talk to us about what is diuretic resistance?
Sure. Diuretic resistance occurs particularly with certain diuretics, such as the one he's taking, when patients actually have swelling in their abdomen and therefore their medications are not absorbed as well, and they also don't get as good a perfusion to the kidneys, and so the kidneys can't work as well even when they do get the medication.
So one possibility that you would suggest to our providers is to change the diuretic he's taking to a stronger diuretic?
Absolutely. There are other medications that are better absorbed in the setting when they have extra fluid in their belly, and so we could certainly try that.
Excellent point. Now, we should never forget that patients don't necessarily need medication changes or medication adjustments to get to goal. Sometimes we need to look into other details that may be as important or even if not more important than just the medication management. Kim, do you have any input about Mr. Smith as well?
I do. You know, one of the things that primary care physicians should consider is that when medicines are viewed as ineffective by their patients, that it tends to lead to more intentional non-adherence. So patients not taking their medicines because they don't believe they're working. And so that takes some careful interview and talking with patients about how they're taking medications and potentially some adjustments to the schedule.
Good points.
Great. So I hope that Dr. Buller, that answers some of your questions regarding this patient. And I'd like to turn, before we come back to the heart failure team in Cleveland, to Dr. Rocco Bassiano, who's a primary care physician in Warren, Ohio, who is a real participant on a regular basis with the heart failure team. And I asked him to share some of his thoughts regarding this program. Dr. Bassiano?
Yeah, thanks. It's been a real privilege for me to be a part of this cardiac scan echo program in Cleveland. I'm an internist and a geriatrician, which means that I am the primary care physician that everybody talks about. My perspective of the program then is really from the front line here. And I believe for us, the beauty and strength of this program has been pretty much twofold. First, we can deliver higher quality cardiac care from the start, and we can do it here in our own community. The didactic and training sessions of the Scan Echo have dramatically improved my ability to handle complex cardiac care. And you haven't got that much of a glimpse of Dr. Ortiz and his team, but he's a dynamo, and I've learned a lot. It's been a great experience. But even more importantly than improving my skills, it allows me to interact with my colleagues here. We have two other physicians and a nurse practitioner, Dr. Satino and Dr. Roberts, and Debbie Wonarski. And it allows me to be a instant access specialist in training here at the Warren Clinic. And that makes it less stressful for really all of us. I mean, they know they can just knock on my door, and I know with their scan echoes I can knock on their door. And it couldn't be more simpler. So, and acquiring and passing on new knowledge has really been a lot of fun for us here. And it's nice to know that someone's thinking about the primary care physician here. We consider ourselves the grunts of the system, but it's been a great thing from that standpoint. The second thing, and even more importantly, is the patients have been incredibly appreciative of the capabilities of obtaining some of their care here as opposed to driving to Cleveland. A lot of the veterans here are 60 to 100 miles away, and they're frequently elderly, they're frequently debilitated, they by definition have a life-threatening illness, and it's very stressful for them to decide to make the trip to Cleveland. So that has been a godsend for a lot of them. And the other factor is that there's a great familiarity with and comfort with them here at our clinic because they know their primary care teams are right around the corner. So if I need to grab their doctor and get them involved, we can do that in a heartbeat. And I guess lastly, this is my hometown. My father was a Marine in the Pacific, but he worked in the steel mills here in Warren, and I worked in the steel mills here in Warren. And every time I treat one of these gentlemen and ladies, I think of my father, and at least we can do is deliver some high quality care to them. And this program really has helped us do that. So thanks.
Thank you, Dr. Bassiano, for sharing your thoughts regarding the impact at both the provider and the patient level. I think that really resonates with those of us that are so committed to this program. I'm wondering, with a couple of minutes, if the heart failure team in Cleveland wants to share some of their observations regarding some of the impact at the provider and the patient level.
Sure, thanks, Sue. One of the issues that I learned when I went to get the initial training for the SCAN program was the fact that this new vision of Dr. Arora was very different, even though it used the health technologies, the computer technologies, the system that we are most familiar with, because it is not a one-to-one, because it is not a patient, a specialist to a provider, but a specialist to a larger group of providers, 12, 15, 18. We in Cleveland, for example, have sites that don't even have yet the visual capabilities for the Polycom, and they log on using telephone lines. So this continues growing. This is really the best example of what he calls a force multiplier. And I really embrace that idea. At the end of the day, when we review 2 to 3 cases, each provider got the knowledge that worked about that particular patient and can then export that information that we, the experts, have given to them. We have given them the tools how to improve the care locally. Also, by the, like Dr. Bassiano said, and thanks for talking so nicely about me, like he said, getting this larger family has allowed the local providers to have a direct communication with us. Not that anybody cannot page me or contact me, but because we interact through the visually through the sessions, we kind of feel that we are closer to any particular time of the day for any questions of the like. So I think that my biggest summary of what ScanEcho is for me is has created mini specialists all across the region. Kim?
So I think that when I think about ScanEcho, what comes to my mind is that it symbolizes the best of what VA care is. You know, one of the things that I feel most satisfied about is that we provide integrated care for patients here in Cleveland. You know, psychology is integrated into medicine. We treat patients in real time at the same time. So we take evidence-based practice and we tailor it and individualize it for the patient. And what ScanEcho does is that it extends that reach into primary care facilities and lets me as a psychologist take that care out into the community-based outpatient clinics where I don't typically work. You know, probably the best example of that was a scan patient who was presented, and after conversation with the PCP, we began to suspect that he had some cognitive impairment. And while there was no one in the CBOC necessarily who was qualified to perform, you know, a real in-depth cognitive evaluation, I was able to supervise it and assess the results from Cleveland, and so we were able to keep the patient at home for that evaluation, yet still provide good quality care. Sherry?
So, and as a clinical pharmacy specialist, again, my role is similar to Kim's in that, you know, I provide kind of a specialized care up here in Cleveland, but there isn't always a counterpart of mine in the local community settings. So having the primary care doctors who've been participating very aware of how important medication titrations and subtle changes in medications can be in terms of keeping patients potentially from being readmitted to the hospital has been a huge asset, I think. And I think we've provided better education and better care to the veterans, particularly in the setting of post-hospital discharge through this program.
Thank you so much to all of our participants. I'm going to make a few concluding comments, but appreciate everyone's participation in sharing really front line and the clinical team what's happening at your level. I think that's important for us to hear in this group who's here today. So I want to conclude by summarizing that I think that this program really is in a position to lead change within the VA and impact veterans and really impact them at the front lines where they have improved access to a number of specialty care areas. Our table over there has more in-depth information if you want to stop by and get a fact sheet about all the different specialty care areas that this is working in and where the locations of that care. I think we heard some important themes in terms of this presentation and earlier this morning. We're building bridges from primary care and specialty care that not only impacts this program, but those interactions and communication is really enhanced and will allow us, even when we're separated by hundreds of miles, as we saw in Colorado, Montana, Alaska, those veterans still have an ability to get better care, to transform the way that we're doing this kind of work. And I really want to thank those folks that support me and this work in our office in specialty care, as well as we're partnering with Primary Care, Healthcare Transformation, and the Office of Rural Health. Together, we've been able to really pull this program together, and I feel significantly impact the way that veteran care is delivered. Thank you so much.